Now, next on our list is Margaret Hellard, my boss, and Deputy Director of the Burnet Institute, Head of Hepatitis Services in the Infectious Diseases Unit at the Alfred Hospital.
Asia Pacific, massive impact of hepatitis B. And I think it's more that it'll set the scene for, say, maybe the discussion that can happen is the barriers to hepatitis B testing and treatment for people living with hepatitis B. The things that we think about are stigma, discrimination, lack of awareness, lack of demand. There's barriers. So there's things that impact on somebody accessing the system. As well, this is really beginning to annoy me. There's healthcare workers as well. There's a systems issue where they may have a lack of awareness of what's going on. The guidelines are super complex where they don't feel like they know what they're doing. They lack support from others in the health system, specialists and the like. They have competing priorities. They're super busy. We have service delivery barriers and chronic disease management issues. To me, when I think about it, these are things that can be sorted out if we really begin to think hard. We need to increase community support to increase community awareness. And I think we cannot underestimate the importance of community in changing what happens in our future. As well, though, we need to simplify testing. We need to get rid of, and my argument is that what we might be doing in high-income countries around diagnostics and testing and monitoring all of that, for many areas of the world, it is not suitable if we are going to get the vast majority of people tested, because so many people have not aware of their hepatitis B, so get tested, and then have simplified guidelines to get more people onto treatment and to monitor people whilst they're on treatment. This does not need to look like it looks like in every high-income country. We need to actually think about how do we get in low and middle-income countries this to be affordable so that people can get tested and on into care, and move care into the community in a hub and spoke approach. We can see with hepatitis C that this is doable. It's also doable with hepatitis B. We've just got to work to do it. Other challenges is, and I just will throw these out there, why aren't the drugs cheaper? Because we know they can be. We know they're actually really cheap, tenofovir and tenofovir, but some countries are still providing them at higher prices. Why is it that some countries, through the prices that they're charging, are actually helping their health systems run by providing these drugs at high prices when they should be cheaper? Why aren't diagnostics cheaper? Who's making the profit between the manufacturer and the provision of tests to somebody? Birth dose vaccine. This is a huge thing that we do actually pretty well in the Asia Pacific compared to other parts of the world, but can be better. Why can't it be moved at the right moment outside the cold chain to get into the villages, to get into the communities much more regularly and easily? Universal health coverage. What does this mean, and how does hepatitis B embrace that? Because that's the way we're going. Sustainable development goals with universal health coverage. Let's make hepatitis B like we manage blood pressure, cardiac disease, diabetes, whatever may be other things. How do we make that happen? How do we make services feel supported to do that? And how do we make sure there's not stigma in services? How do we build but not lose from the COVID-19 pandemic the changes that we've done in telehealth, in all sorts of things, in strengthening surveillance systems? How do we make sure hepatitis B benefits from this? And cure will come, but we don't have it at the moment. We have many things we can do right now whilst we wait for cure, and ensure that when we hit the ground running when cure comes, because if we think about hepatitis C and how long it's taken us, even with cure, to get into good positions, what's the things we need to be doing right now with our current drugs that really manage hepatitis B well, but we just don't have enough people having them, so that when we do get cure, and I'm very comfortable with functional cure, but I'll just call it cure, that can be done. So for me, tilting at windmills perhaps, or as I say, doing impossible things, the Queen of Hearts from Alice in Wonderland. They're both Western references. So, and I was trying to work out what an Asian reference was the equivalent of the Don Quixote, who was a mythical person from Spain who used to have fights where he would tilt at windmills, thinking that they were monsters and he was going to beat them. But I don't think we're tilting at windmills. But I do think we have to believe that it's possible. So impossible things are possible, and that is the Western reference for the Queen of Hearts in Alice in Wonderland. But importantly, to ensure we are not doing what we've done for the last 5 years, because it's not going to, last 10 years, is not going to achieve elimination. We need people power. We need all of us and our communities to say, we don't want these deaths, we don't want this disease, and we're all going to do something about it. So that's the end of my presentation, Jack.
Thank you so much for that, Margaret. That was fantastic. And thank you for dealing so beautifully with the kind of processes, interesting kind of processes that we've been experiencing.